Well, good morning, everyone. Thanks for having me here. Saturday morning in Waterloo. I was just in Saskatoon. I was at the Alta Hotel last night, drove up. It was nice and simple to get over here. So anyways, thanks for having me this morning. It's my second time being able to present here at the University of Waterloo. I did some work with some students a few years ago. So I'm a pharmacist, went to Dell, and Thunder Bay is home for me, land of the ice and snow. And over the last couple of years, I've gone through a lot of interesting experiences trying to figure out how to make pharmacy work and really expanding my role beyond pharmacy into multidisciplinary clinics. Today, I've been invited to present on a pharmacist operating as an independent consultant. I wanted to frame what I can speak to with that. Now, I know there are some pharmacists that are completely separate from the pharmacy, right? You know, the bricks and mortar out practicing separate. I've heard a lot of interesting cases of that. Now, personally, I don't have any experience working completely separate from a pharmacy, but I would like to share some interesting approaches I have taken with some of our team members that are working sort of at an arm's reach kind of relationship where they're not a full employee, they're able to do consults at their own pace, their own therapeutic area of interest. Before I get into that, I wanted to kind of set the framework and talk about some of the changes in pharmacy, which we're all aware of, what I've done in the dispensary to set it up so that these pharmacists can practice to their full potential and work with other providers inside the clinics that we have and operate. So, Dave, thank you for the kind introduction. So I've been busy trying to better my learning over the last couple of years. So Dave kind of mentioned all that. So this year I rebranded my pharmacies and clinics to Oak Medical Arts. They all had different names and different colors, and it was getting really hard to promote and network them. So we went with Oak, simple, it's kind of a nice word, stands for strength, wisdom, strength, life, that sort of thing. So it's a nice, easy brand, but we're able to promote that they're all locally owned. And in Thunder Bay, that's really important. People are coming to our clinics for the very fact of, well, I don't want to go to one of the big corporate stores. Because Thunder Bay is a bit of a smaller town, so it's kind of an easy marketing strategy for me, but it's true as well. Now, what is Oak? You might be kind of surprised. I've actually diminished the presence of pharmacy within these locations. It's not a pharmacy doing chiropractor care and walk-in clinic. Oak is a clinic that involves walk-in, pharmacy, massage therapy, chiropractics, foot care, addiction medicine. A pharmacy doing chiropractic care, it's kind of weird. It's kind of hard to promote and pitch, whereas a clinic can really do absolutely anything. And so that's the approach that I've taken with this. And I will get into some of these different providers, but really what we've been able to do is have all of these team members inward-facing clinics. They're working with one another. The chiropractor is showing an x-ray to the physician, and if they're having back pain and they need some medications, they'll kick them over to pharmacy. You know, I don't know anything about anatomy in the back, but I know a lot more about medications than the chiropractors in this specific example. So it goes without saying, that type of care we know is going to do a lot better than each person trying to work solo independently in their own little silo. So these are the locations I have. I was just in Saskatoon. I've had some interest out there. Thunder Bay is quite a similar city to Saskatoon, similar issues. So I'm working on some projects out in Saskatoon of all places. That's where I came from earlier in the week. Dave already mentioned about Corazon, so we're doing some consulting work and really trying to share some of these best practices. So if there's anything of interest here, we might be able to get you set up with Corazon for to roll some of these on in your locations as well. So just get passes. So we have education online that we can provide. And I find finding the hardware and devices is one of the tough things. If you're interested in doing cholesterol testing, where do you get the machine? INR, where do you get the machine? Osteoporosis bone density screening. You know, there's ultrasound devices that can test for bone density. So I've been trying to facilitate some of that because some of these devices are in different countries. And then the last one Dave mentioned is later this afternoon, I'm going to be going to a site downtown Toronto. We're going to be setting them up for pharmacist-led telemedicine. Now, there's a clinic downtown. They have a nice pharmacy. They renovated some new clinic exam rooms. It looks great. It's empty. It's sat empty for the last year. And this pharmacy wants to bring providers in, but they've never done this before. So what we did in Thunder Bay is we were able to have our new locations as they pop up. We have one central location that's running well. We have physicians, nurse practitioners. The new site, it's really hard to recruit for. So what we did is we have the pharmacists do standardized consultations for simple stuff, common minor ailments, walk-in appropriate clients at the satellite site. And we connect them with the physician and nurse practitioner over telemedicine through a secure connection. The pharmacist does the assessment, the blood pressure, the recommendations. We're all charting in the same EMR system between the two locations. And then the provider sees them over the telemedicine, provides an assessment and generates a script, whether it's for a medication or for a therapy. And then we hand it to the patient, and 90% of the time they hand it back to us and we go ahead and fill it. So later this afternoon, I'm going to be setting up a site down here in Toronto. They're going to be seeing our providers in Thunder Bay. There's a lot of telemedicine out there, but most of them is run with a nurse or a new medical graduate. So this is the first time having a pharmacist really running a satellite site, and the practitioners really relying on them to do a proper assessment. So that's a little background on what I've been up to last little bit. So I decided to eliminate sleeping and eating to try to get everything done, but it's been really fun. But you can see there's a connection and synergy amongst everything I do. It's rooted in healthcare, and really the pharmacist, the patient's at the center of care, but really I'm trying to have the pharmacist central to the operations of assisting the patient. So just to set the framework, we already know, Pharmageddon's upon us, all the continued and looming changes in our healthcare system. Now, I know we're aware of all these, but it's kind of an interesting exercise if you start to look at the trends and patterns. And I graduated in 2013, and we were already in the middle of many of these changes. I call the 2000s the good old days. Dispensing was good. You had a pulse and a pharmacy license. You made a lot of money. Financially, there wasn't a big motivation to diversify, to do all these different and complex things. As time progressed, all these different acts and changes, this red bar, I just made these arbitrary numbers. Say the pharmacy's billing $50,000 a month, or they're retaining $50,000 in net revenue. Over time, that dispensing revenue is continuing to shrink with these changes. And I know our profession across the country has been advocating for expanded services coupled with reimbursement, but it's, the challenge is, does this increase in clinical services offset all the dispensary changes? And I know it hasn't been quite on par, and the challenges to do so continue to get more difficult. But when I looked through all these changes and took a look, it is a really concerning trend. Back in 2006, reductions to dispensing fees and the Transparency Drug Act. So this is where they're starting to look at the professional allowance, generic rebates, the big elephant in the room we don't like to talk about. What I thought was interesting, they said the dispensing fee is intended to cover the direct costs, they say rent and labor, associated with dispensing prescriptions. I said, oh, okay, I thought, dispensing fee is kind of how we made our living, but they're saying it's just there to kind of cover your net costs. Well, then in 2007, there were additional changes, and this time in Ontario, there's a reduction in markup with ODB from 10% to 8%. And the language here says markup is intended to cover distribution and inventory costs. And I'm thinking, as I was putting this presentation here, I'm thinking the government's only thinking we're just trying to cover your costs, but where's the sustainability in that? Some of the larger groups, very good ideas. Some of them tried to create their own generic private labels, but that was completely smacked down. That was in about 2010. So I think Shoppers and Rexall tried to have their own generic private brands that they either acquired or set up, but government said no, this doesn't fit into our strategy. Pharmacies shouldn't be making money exclusively, should be from providing professional healthcare services instead of the revenues of drug manufacturers by setting up their own private label subsidiaries. So again, another slap to pharmacy. The big guys are trying to make something work for the big corps, right? 2015, I believe, we had change on test strip limitations. So they wanted people to more appropriately use test strips for diabetes glucose monitoring. So again, another hit to dispensing. Further markup reductions in 2016, 2017 with high-cost medications going from 8% to 6%. We see this in some of the other provinces too. I was talking to people in Saskatchewan. Some of their markups are capped. As soon as the drug's over $200 markup, they don't pay the difference on it. So they have to do weird stuff like daily dispensing to get stuff like Harvonies, Hepclusas, and Hep C drugs covered. So again, we see these continued shrinkages. And then the 90-day allotments on prescription dispensing, right? Extending the number of days required. Again, that reduces the number of dispensing fees we've had to work with. Meds check. expanded to a 15-page beast of a document that's been challenging for everyone to try to implement. As I was saying, okay, it makes sense they're just decreasing dispensing revenue but increasing clinical services. Well, this threw a big wrench in it. In my personal opinion, I actually found this incredibly offensive, that they would structure our consults so rigorously. And I didn't fully realize how angry, well, I got angry after I looked at some of my other providers I work with. I look at the chiropractor that I work with. They don't have anything structured to this extent. They don't have a 15-page document that they fill out every time they assess a patient. My physicians don't do this. The massage therapists I work with don't do this. The dietitians don't do this. And I respect that the government wanted us to provide more value with our meds checks, but to this extent, again, I find is very frustrating, and I do find the extent of the documentation almost somewhat offensive. Some of my colleagues out in Saskatoon, they're big into compounding, and we're seeing increased regulations on this too. Again, I understand the safety aspect, but they're starting to tighten up the regulations and the startup costs associated with doing compounding. You need to have, in some of these places, it looks like the trends are going towards you're going to have these really sterile prep rooms that are really expensive to set up, a lot of procedures, protocols, and then the licenses to pay for compounding are also really expensive. So, you know, we get squeezed here, let's diversify into compounding or other areas, and then they're getting kind of crunched down there too. I thought this was an interesting one. We saw the Ontario government recommended we were going to open up the drug coverage to youth. But okay, that's a nice initiative, we'll have more people covered. And then I saw this analysis on minimum wage increasing, and Toronto Dominion Bank proposed that the changes to minimum wage would likely be concentrated among young workers. So I thought, oh, maybe the government was planning, let's give them free health care because the increase in minimum wage maybe is going to reduce some of their jobs. So I don't know, I'm not a big analysis on banks, but again, this is going to come out of the community pharmacist bottom line. Federal government just clears war on small businesses. So Dave, you're probably presenting on this in some of your classes you mentioned there. You know, they're changing small business revenue taxation, so this is going to affect small pharmacy as well. We see proposed changes to some of the third-party payers. They're going towards value-based pharmacy, which is an American model, which I don't fully support. And I got this one on my phone yesterday morning. I was like, oh yeah, I forgot. We're also looking at federal health care. $42 billion a year in savings. Well, where's that $42 billion going to come out of? It's either the pharma industry or pharmacy. So anyways, enough said. I know you're saying, like, Brian, we know you're depressing us. I thought you were here to rally the troops. But I thought it was an interesting exercise to look at the trends and see what's going on. And again, setting the stage for what I'm here to share with you today. My way is, of course, not the only way to diversify and have a long-term solution for your pharmacy or your independent practice. But you better have a plan in place, because these changes are coming more and more frequently. And I don't know what the next creative idea someone's going to come up with, but it seems that pharmacy is continuously under siege here. All right, deep breath. It's okay, guys. We're going to get through this. We're going to be okay. One thing I talk about in my farm, and when I have rolled out these the pharmacy-specific initiatives, is medication synchronization, autofill, the appointment-based model. You can kind of call it all the same thing. They're all quite similar, but really streamlining the dispensary process. Not super exciting, but when you have a patient on 5 medications and all of those prescriptions are being filled on the same day, delivered on the same day, proactively calling the patient that the stuff is due, that sets up a ton of efficiencies, cost savings. You know when the patient's coming in next month. If they come in today, today's September 29th, September 30th, they're coming in October 30th for their next pickup. I know the date they're coming in. I can book them in for a meds check, an INR consultation, a cholesterol check, a wellness check, whatever you guys are interested in, ABO blood type testing, whatever your mind can create. The idea of having a solid foundation for your dispensary, I feel, is critical to set you up to have time to do all the fun stuff. I had a pharmacist, her name is Michaela. She is a Toronto graduate. She moved from New Liskeard, and she was in a store that did about 200 scripts a day. My first site, River Terrace, also does 200 scripts a day. And she said the difference from moving from that site that just was your typical patient calls in a fill, they come in the store, Or they show up in the store and they wait, and then they pick it up and they go. And then they're calling again the next day. And then next week something's out of refills and you gotta wait with the doctor. She said that workflow, which is pretty standard, coming over to our site where we have MedSync and autofill ABM model in place, she said she can't believe the difference. You walk in, you think the pharmacy's dead, but all of the work's happening proactively. Specifically what we do, we get everybody on MedSync. Everybody's on it. We're not asking permission. We explain to them what the program's about, or the initiative. We say, how would you like to have all your scripts filled on the same day? Who's going to say no to that? It's the easiest program to pitch. But once they're all synced up, it makes a big difference. Now, I'm not here today to speak on MedSync, but if this is something you consider, you can do it in about 3 months. You think most people get 1 to 3 month allotments of their prescriptions. That's enough time to get the majority of your workflow synced up. So I say before you start trying to do big initiatives on the clinical programs and the fun stuff, you spend about 3 months getting stuff synchronized. Month 1, maybe you get 30% of your workflow done up. Month 2, 60, month 3, maybe 90%. That's a good time to start having structured appointments, pre-booked appointments with your pharmacy team. Now, the term ABM, appointment-based model, is quite big in the States. Like I said, you can kind of call it whatever you want, but their definition is what we have here. Appointment-based model is a patient care service designed to improve patients' adherence to medications and build efficiencies in pharmacy ops. Each patient enrolled in ABM has a designated appointment day to pick up all medications. Getting them synced up, getting them on autofill, having them a booked appointment to pick up their meds, and better yet, a consultation with the pharmacist for something. What does it mean to you? I made up this little level system. This is all arbitrary. This is me just trying to think of, well, how complex can you make it? Let's say right now we have no initiatives to proactively fill prescriptions. Let's say we're all at level 0. Patients call you, they show up at your store, they set the workflow pace for you. The next step, let's say we got them all synced up, but you're not actively calling the patients. Let's say that's level 1. So all of the scripts are synced up, but we're still letting the patient drive the workflow. So they're coming in for all their meds on the same day, but they're still driving the pace. When you make the flip to the proactive workflow, this is where there's some sort of system in place to notify the patient. So meds are synced. I'm not promoting the Kroll software, but there's a little button called autofill. I click it. If it's a 30-day supply, day 30 it shows up in my workflow for filling. If I've got the meds already synced and it's an autofill, all 5 of that patient's meds pop up in my queue and I go ahead and fill them. What this means is in the morning, I have a pharmacy assistant come in at about 8:30, about half hour before we open. She processes all the MedSync and autofills. I show up at 9, and about a third of my pharmacy workflow volume is already filled, ready for me to check. 10 o'clock, I've checked about, well, pretty much all the prescriptions. 11, 12, 1 o'clock on the day, my pharmacy team's calling the patient to say, hey, your scripts are due for fill today. Or the pharmacist noted you're taking Depo-Provera, it's due for fill, you probably want to get that filled. You know, no pregnancies, ha ha ha. But did you know that Depo-Provera increased risk of osteoporosis? We're doing bone density consultations in the pharmacy. Now I know you're 27, but would you like to come in for an appointment? Whatever the pitch is, whatever your initiative that you're interested in, that's what we can start to set up with these scheduled appointment dates, consultations. You can integrate point-of-care testing. I'm sure you've all heard John Papasturgio talk about the million fun different technology pieces you can implement. What I do is I try to arrange collaborative care appointments with providers. So if they're coming in, maybe they need to see the nurse practitioner for refills. Maybe I can introduce them to the chiropractor. Maybe I can introduce them to the foot care nurse because they have diabetes. So there's lots of different opportunities you can take with structuring these appointments. Again, it takes about, you can do it in about 3 months in your workflow, whether it's your pharmacy or you're working in the site, huge efficiencies. All meds, same day. You don't know when they're coming back to the pharmacy. That sets it right up. In terms of tools, you don't really need much to do this. There are softwares out there. I've never felt the need to use them. You know, you have some sort of scheduling system. If you're booking them in, you can use Google Calendar, you can use an agenda, you can use different software tablets and websites have plugins for this. And again, the purpose piece, we know when they're coming to the pharmacy, do something special and meaningful with them. Whether it's a meds check, asking them about their meds, doing consultations, appointing your test or a program. So that's what this really sets you up for. Now, the clinical programming, for time here, clinical programming, there's almost no limit. Every therapeutic area, there's an opportunity to do some sort of consultation with them. And I know I threw out a funny one earlier. I said ABO blood type testing. I've never done it, but I'm just saying something as random as that, there's probably a couple people out there that say, I'd like to know what my blood type is. But you can do something as vague and kind of fringes that's a little bit special, or you can maybe look at something more traditional, like a cardiovascular disease assessment. We will check your cholesterol and do a Framingham risk assessment on you. Now, I've kind of grouped these into three main categories. There's kind of your acute consultations, your chronic, and preventative. And there's a lot of overlap between them. In terms of acute, these are some of the things that fit in well, that can integrate in well with a walk-in clinic type setting or with other practitioners. So streptococcus testing, mouth swab. We can see if the patient has sore throat, do a structured consultation. If the test comes back positive for the strep A, it's a rapid qualitative test, detection of strep A antigen, comes back positive, run the test. There's a couple manufacturers that produce this machinery. The BD Veritor is one, and BTNX has more of a laboratory dip kit. And at the end of it, if you have a positive result, you're able to make recommendations to a physician for antibiotic therapy. Oh, and at the same time, maybe something to help with pain, and maybe a probiotic to avoid any antibiotic-associated diarrhea. So you can take these consultations pretty far. H. pylori screening. Depending on the community you practice in, there are some populations that have higher risk. Aboriginals, those from Asian countries, they seem to have higher prevalence of H. pylori. But if I have patients that come in and they're starting anti-inflammatory therapy for probably a long time, they've got arthritis in their knees, or they play a lot of sports or golf all summer, and they're starting an anti-inflammatory, I would say, well, maybe it'd be worthwhile screening you for H. pylori. Would you like to pay for it? So again, this is a blood antigen test. We're seeing, has the body ever been exposed to H. pylori bacteria? This is a little detail aid that I have in my pharmacy that I hand out, what's upsetting your stomach. And on the back, I just compare traditional testing versus what we can do in the pharmacy. So the urea breath test is a really unpleasant test to have this done versus I can do a quick little finger poke in the pharmacy and see if you have a positive result for H. pylori. And the accuracy of these devices are pretty good. I know the documentation form I have here is a little small, but I put the big words up here that we're looking for. What's the history of their medication therapy? Do they have any provoking agents that, these are probably upsetting your stomach. You probably don't have H. pylori. And then all the social or lifestyle options that can upset the stomach. So, if you drink coffee, smoke, drink alcohol, and eat spicy foods, you're going to have some heartburn, indigestion, upset stomach. So, red flags. Do you have any bleeding? All these sorts of things. If you proceed to perform the H. pylori test, we have the 4 standard therapy options ready to go that we can recommend to the physician. So if you're in a standalone pharmacy, you can fax this off or call a physician. If you're in a collaborative environment, you can walk this over to the nurse practitioner or physician. Or maybe you go so far as to have a collaborative practice agreement or a medical directive where it comes back positive, just go for it. It depends on your relationships with providers. The last acute care test I mentioned is influenza testing. So I personally haven't done this one, but John Papasturgio, he's a big fan of this one in the fall time. And again, it's looking for influenza A, B, if we have a positive response for it. So again, it's a blood type test. You get a result back and it tells you if we have influenza. In terms of chronic disease testing, again, there's a lot that we can pick from for everywhere from diabetes to lipids to osteoporosis, INR, pain management. When you're deciding which programs you'd like to go on, think about the patient experience with these. The chronic disease ones are a bit tougher to pitch and to sell. Stuff like cholesterol, I don't feel my cholesterol's down. I don't feel any different. My doctor checks it. Well, do you know what your cholesterol levels are? No, they said I have good cholesterol. Right? So the discussions for these are a little more difficult, whereas if someone's coming in and they're sick, their throat's sore, they're actively in pain looking for an option, they're a little more willing to pay for these different services. Diabetes, there's a huge range of services that you're able to offer. A1C testing is a common one, so There's an A1C Now device, again, a blood test, 5 minutes, you can get an A1C reading back. Monofilament testing, looking at people's feet. This was surprising for me that my very first consultation, I ended up with a patient who would come in, she was wearing Crocs. I said, hey, have you ever had your feet looked at? And take off the Crocs, she has ulcers on her feet, and no one had ever really looked at her feet. And I know as a pharmacist, we usually see people from the counter up. I spend a lot of time trying to look at people's legs. Are they puffy? Are they swollen? So there are standardized approaches you can do for monofilament testing. And this is a really good screening initiative to see if patients' diabetes is controlled or not, and we don't want them to lose protective sensation. So there's a standard scoring system. You can check the bottom of the feet for sensation, and at the end of it, you can recommend they have further follow-up. Maybe they need to see a chiropodist, or maybe we need to look at their neuropathic medications, or maybe this is an opportunity to partner, collaborate with a foot care nurse. Lipid screening for cholesterol, very similar. You can integrate this in with cardiovascular disease assessments. This is my promotional detail aid. How old is your heart? And we outline the programs, so we'll check your blood pressure, do your cholesterol. Now, as I go through these programs, and if you decide there's one that you're going to implement, always be careful what you're actually promoting to the patient. Am I promoting a cholesterol check, or is it a heart assessment? Am I checking your osteoporosis bone density, or am I checking your T-score? Am I checking your A1C, or is it a diabetes consultation? So always think of that when you're trying to pitch and promote with the patient, that the test is only part of the service that you're offering. So I mentioned about osteoporosis bone density. So we have an ultrasound device. It's not the gold standard. It's not as accurate as the DEXA X-ray scan. But again, let's say you're a 30-year-old female taking Depo-Provera, going to use it for the next 5-10 years, slight increased risk of osteoporosis. You're not going to have a DEXA X-ray scan until you're 60. But what is your risk right now? There are good predictive tools out there. The WHO has one called a FRAX risk calculator. You can go online and plug all the numbers in, your age, your weight, your height. And if you have a T-score from the result, or if you don't have a T-score, you can still predict and estimate someone's risk of osteoporosis. So I always show this nice little graph to people, say, well, if you're on a good trajectory and you eat a lot of milk, had a lot of milk and dairy, and you exercise, your bone health is going to go like this. But if you had a bad start, you're increased risk. Or unfortunately, you're 50-50 chance you're a female here. When you go through menopause, you're having increased risk once that hits due to hormonal changes. So, yeah, another initiative that we can look at rolling out. INR warfarin testing. I'm not going to steal Dr. Nagy's thunder, but I did take his Waterloo course, and we implemented INR testing in our pharmacy, and this has probably been one of my most successful programs from a business standpoint. People on warfarin are usually on a ton of other medications. And when I sync their profiles up, if we put them in blister packs and we do the warfarin testing on site, we can get very specific, precise doses of their warfarin. And our time in therapeutic range has been amazing with these patients. And we've now kind of been the second biggest INR provider in Thunder Bay. There's one site that's been doing it forever, but they never shared their results with the providers. They never went out and had discussions with the patients. And after talking to Dr. Nagy, I noticed that their site, anytime a patient's INR dropped below 2, they were throwing them on Lovenox. I was thinking, this is not very good therapy, and we get patients transferring over, their INR would drop below 2, and they say, oh, do you have to put me on the needles right now? And I was like, no, Dr. Nagy said no. So. But it's just interesting, right? There's a place that's been doing it forever, and you look into what they've been doing, and I have a fresh look at it, and you say, wow, maybe there's areas to improve. So at least people have options now in our city for different INR testing. And I won't get into the details of it too much, but what we do to make it sustainable, we don't charge for the service, but we only give them enough warfarin to get to their next appointment. And so we're able to recoup costs with a dispensing fee, and it makes people really good at showing up for appointments. I don't handcuff them and make them feel like they're tied to us, but when they only have enough to get to the next appointment, they get really good at showing up for those appointments. And we're booking them in, we're calling them. We give them like a 1 or 2 days extra in the event it's winter and there's a snowstorm coming out. But we're not giving them the bottle of 100 tablets that they just get to play around with at home. So we've had a lot of good success with that approach, and it's helped contain costs as well for offering the testing. Pain optimization testing, really big in Thunder Bay, Ontario, because there's a lot of patients on non-ideal regimens. Bottle of Tylenol 3s, that's it. No long-acting, no adjunct therapy, no side effect management. So many opportunities for pharma opinions. Pain is in your face. People want to improve their pain. And I look at some of my colleagues in Saskatchewan that are doing a lot of compounding, and they can do a lot of advanced work beyond my traditional therapy of long-acting adjunct medications, etc. But decreasing your pain score, optimizing regimens, reduce medication side effects. This has had a lot of success in our community as well. I'll run through the preventative ones here really quickly, because I would like to get to the collaborative piece. Immunizations, flu season's coming up. Really good opportunity when you're giving your flu shot. What about, do you have your pneumococcal? Do you have your Zostavax? Do you have your tetanus? Do you have your diphtheria? All of those drugs have a DIN. All of those drugs are potentials for pharmaceutical opinions. Whether you end up dispensing or administering these vaccines, there is a potential for pharmaceutical opinions with these. Pharmacogenomic testing, I saw Waterloo has some CE training on this. I did give it a go for a little bit. It's a lot of work, but screening patients on drug response testing for how fast they metabolize drugs. A lot of opportunities here to improve pharmacotherapy and figure out why their pain meds aren't working, why the antidepressants aren't working, because they metabolize differently. Smoking cessation, there's opportunities for, let's skip to that one. We have a lung carbon monoxide detector where we can screen for how clean are your lungs. So it's a nice little test that we accompany with our point of care testing, or with our smoking cessation consults. Naloxone, we're giving it to absolutely everybody in Thunder Bay. We've given out about 500 kits in the last 3 months to health providers and to patients. Little grandma on codeine, patient on methadone, patient coming off the street looking for clean supplies, we're giving them the naloxone kits. And then the last one I'll mention here is arrhythmia screening. Right? And I apologize, I know I'm rushing through the different pieces here, but I wanted to get to the collaborative part. But the point being here, I rushed through them quickly, but there's so many ideas here. And what I've shown you is only a small piece of what you could get into. There's thyroid testing, there's stuff to do with hormones, there's women's health, there's urogenitary health. There's so much that we can get into. And I think the trick here is either yourselves or your colleagues or your employees or your pharmacists is you need to spark their interest in something, give them a blank canvas and ask, what would you like to do in your practice? How can I make it happen? How do we find a model that's sustainable that will make it work? And so this will kind of jump into, I guess, the purpose of my presentation is the independent consultant piece. Scope of practice is expanding, that's great. Showed you a ton of fun technology and toys. What I think we need to do as a profession at the corporate level, the store ownership level, the management level, the academia, is we need to think of alternatives to the traditional hourly wage. We need to think of different ways for pharmacists to work and practice in our locations that aren't in that traditional employee relationship. There's nothing wrong with having someone paid at an hourly wage, but that's not what everybody wants. Now what I mean, and this is a spectrum, this is simplifying things, but we have our traditional employee relationship, hourly wage, benefits, set schedule, defined duties, time limitations on activities. Then you can't spend an hour and a half on a meds check, you get 30 minutes. So I'm paying you, and if you're going over and above that, you're losing me money to provide the service. It's not sustainable, right? You have those limitations in place. Where I've been operating recently is having these independent providers on site. And instead of the hourly wage, we've gone with a simple overhead model. This is what the docs do, the chiros do, the massage therapists, the full care nurses. All these providers are on a percentage overhead. And if you're ever talking to physicians, that's one of their first questions they ask if they're looking at joining a clinic. Say, what's the overhead? What's the split? And anywhere from 20 to 40% is pretty common in these practices. So what I've done, I have a couple pharmacists who say, you're not paying your hourly. I'm going to let you retain 75% of your billings. You can take as much or as little time as you want. You're responsible to document as per our standards. And I'm going to let you, we'll mutually agree on a schedule. We'll say Tuesday afternoons you do diabetes consults. Thursdays you're going to do bone densities. And really working with them to figure out a system and a schedule that works. So this is really what I think Works really well in the community pharmacy model. As I mentioned, I don't have any experience with the pharmacist working completely separate from the pharmacy, but I think we need to look at these alternative models and structures to get pharmacists to be able to practice to their full potential. There is the opportunity for collaboration here as well. There are legal considerations, and I talked to Dave for like 5 seconds here before class, but the concept of getting an HST number versus full incorporation. These are some important pieces that we need to think about. Collecting of revenues and fees. There's agency agreements if we're collecting money on behalf of a provider. There is potential tax issues that we need to avoid. And then there's a liability piece. What happens if that pharmacist, they're not an employee, they poke someone's finger and it gets infected? How does the liability work for that? So making sure everyone has insurance in place and patients are consenting to the services that we're receiving. In terms of revenue and rates, I know this is always difficult for us, is what do we charge? Oh, and I hate charging people for services, and it's so difficult selling them on it. My advice is sell them on the service first, and if they're interested, then you share the cost piece with them. If you say, you know, you're at increased risk of osteoporosis for blah, 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 would you be interested in a test? If they say no, they're not going to care what the price is. If they say they're interested, then you simply say, the cost for the service is $50. We're not able to bill for the service, and this is to cover our costs with the pharmacist's time. And I find about 4 to 5 people, if they're interested in the service, they're fine with that message. In terms of what rates to pick, I was having a bit of trouble trying to figure out what's a fair rate to go with, but what I noticed is pretty much all my providers on average are about $50 for 30-minute appointment. That seems to be about the consistent average. Chiropractor initial assessment takes about 30 to 60 minutes, $70. 20-minute follow-up, $40. That's close to 50. Massage therapy, all the different time ranges here. My guys said, yeah, 30 minutes is about $50, $60. Okay. 30 minutes of pharmacist time versus a registered massage therapist sounds about right. Nursing foot care, the market rate in town happens to be $50. So that's what I've kind of set the majority of my prices with for our programs. And if you just want a simple number, $50 is pretty reasonable for most of the standard programmings that you can do. So if you're doing a cholesterol test or a health assessment, $50 for 30 minutes covers your costs. Pharmacist makes a bit of time on that. You know, H. pylori screening a little bit quicker. I have it at $25 for 15 minutes. Osteoporosis bone density, $50 for 30-minute assessment. Smoking cessation, $50 for 30-minute assessment. So in terms of the revenues and the rates, you know, you can refer to your fee guide. For my recommendation, $50, 30-minute appointment, really simple benchmark number you guys can work with. With more advanced training, it's totally reasonable. I see pharmacists charging $100, $200 for hormone consultations or full compounding assessments. So if you have a lot of training and a lot to offer, this is totally reasonable too, but pick a number and work with it, right? The last piece I'll mention before I hand it off here is whether it's yourself, a colleague, or an employee, or an independent pharmacist, there's only 3 simple tools I recommend you arm them with to get them started. And that is a detail aid. And I sound like a pharmaceutical rep, a detail aid. It's outlining what the program involves, something that's patient-specific. A referral pad, really simple, make something up in Excel. Doctors, nurses, providers, they love checking boxes. They love slapping labels and stuff and checking boxes. You can get referral pads made up for pretty cheap, for pretty affordable. And the last piece is a notification of service letter. If you're starting to do cholesterol testing or pharmacogenomic testing, there's going to be questions. It's better to send a nice little letter out, a fax, a mailer, an email, drop it off in person, outlining to the provider what the service entails. It saves a lot of headache, a lot of questions from the provider or pushback. So in terms of the detail aids, these are all the different ones that I use, and you've got to see a few of them as I presented here, but I go with kind of an interesting question. How old are your bones? How clean are your lungs? How old is your heart? You can see kind of a simple theme that I've kind of gone along with here in terms of these services, and then find a really cool picture. It's about the extent of what I've done with my programming detail aids here. But yeah, you just need something nice to show the patient. This is what I'd like to do for you. Maybe you're not interested today, but take it home. Think about it. You know where to find us. In terms of a referral pad, just throw down whatever options you want. You can have general heart assessment consult, or you can have a cholesterol test, blood pressure test, Framingham risk score. The doc's gonna just do a big check on the whole thing and throw a label on it and give it anyway. So here's an example of our foot care one. Throw the label there, general nursing foot care assessment plus treatment. Most of the docs just check that box. But specific nursing care assessment and treatments, there's bunions, ankle fractures, fungus. Found a picture of some feet to throw down on there. I just made this up in about 30 minutes. Say, all right, this works. And the doctors are like, that looks really good. I'm going to use it. And then room for space to write. So again, whatever initiative you're doing, make something simple like this. You don't have to get a nice fancy tear pad. You can literally get a piece of paper, make a bunch, cut them all in half, and put a little clippy tab on it and give it. That'll work just fine. And in terms of a notification of service letter, picture walking into the doctor and they're going to say, sounds cool. What does the bone density testing involve? They're going to ask, how long does it take? How much does it cost? How do I refer? What do we do with the result? All of those things, like picture a conversation, put the answers on a sheet of paper. That's your notification of service letter. That outlines what you're doing. So that is my, I'm flipping right here. That's my recommendation for arming either yourselves, colleagues, or your practitioners, is those three things. A detail aid, referral pad, notification of service letter. So I'm going to pause here and see if anybody has any questions. I hope I've presented kind of a compelling case of the Pharmageddon, doom and gloom. Try to get the pharmacy lined up with some MedSync appointment-based models. So then you have time to do all the fun stuff. And how you do the fun stuff, think about different ways of reimbursing and compensating, either pitching yourselves to your employers or sites, or your own team members, provide them with alternative options that they can work with here too. So with that, I just want to say thank you for giving me time to present here, and happy to take any questions if we have some time, Dave.
All right, thank you very much. We have time for a couple of questions for Bryan. Nick.
Bryan, thank you for that. From the fun stuff, what has been your most successful program, and why do you think so? And then what has been the most challenging, and how are you trying to improve that? So the fun's gonna be
Yeah, so disclosure, all of my sites have been brand new startups, so starting from scratch. I found the INR warfarin program has been great for getting clients in. They're on a lot of other prescriptions. They have a lot of other comorbidities, so I can get them in for that. And even if I run it cost neutral, I have then the opportunity, they're coming in for their INR on a regular basis, I can promote, why don't we check your cholesterol next time? You have COPD, let's check how your lungs are doing. So INR for me has been easier to implement, a lot of uptake by physicians, cost is pretty reasonable, and in terms of the revenue piece, it's quite checked off. So that's my suggestion for a new pharmacy starting out. Second one I'll mention is the pain optimization. Again, Thunder Bay has a lot of specific issues. The pain optimization program doesn't have a tool per se. There's no bloodletting, there's no complex test, it's just a standardized pain score. And I didn't need to do any additional training. I know a bottle of Tylenol 3s is not ideal therapy. So long-acting, short-acting, adjunct pain medications, that one's been really well to implement too. So those two. The more difficult piece is what I've been trying to share today, is figure out how do I implement it in my pharmacy. I can do all of these programs, I can do it, but I'm busy trying to keep all of these sites running and signing checks and paying the bills and trying to do the whole business piece. So my challenge has been, when I'm not at the site, how do I get the team members to do it themselves? And pushing a program on them saying, I want you to do bone density, doesn't work. You need to open up the options, say, what would you like to do? Maybe give them a couple ideas, and then really work with them, what can I take off your plate to let you do the fun stuff? So that's been the biggest challenge for me, is finding what is each person motivated in. And even the team, the pharmacy assistants, how do I get them to do this on top of all the other stuff we dump on top of them?
Oh.
That was great. Bryan, thanks very much for that. I teach a fourth-year course on advanced ambulatory care.
Yep.
And I wish this class could have come to see this presentation, because part of what I've been trying to impart to them in that class is exactly what you're saying, that we need to do this stuff, because of Pharmageddon, because of all of these pressures that are on the
Mhm.
profession. I guess my question is, and the question that they would have is are there resources that they can go to get started with the how, sort of the nuts and bolts of actually
Mhm.
starting to implement stuff like this? Because I think that sometimes that's the hardest part.
Where do you start?
Getting involved with.
Yeah, and that's the challenge I've been finding with smoking cessation. The device that we use, it's from the United Kingdom. You can't just call them up and say ship it over on McKesson tomorrow morning, right? So where's the device? Where's the guidelines on this? You got to pull that stuff out. Those guidelines are long; they're 100 pages long. I just want the one page on how to do this stuff. So over time, you kind of get a pattern. You know where there's the therapeutic organizations like the CHEP for heart disease, the Osteoporosis Society of Canada. I go to a lot of them for my really quick and easy detail aids. There's a lot of point of care devices, but those aren't always essential. So I guess to answer your question, like it's taken time to figure out all these different pieces. You need to start somewhere. I'm not here to promote Corazon, but that's really a lot of the work we're trying to do is centralize a lot of that stuff where you get the documentation, the hardware, the devices, because that's the question everybody has. Yeah. So
It's almost like you could have a consulting service to help people set these types of things up.
Mhm.
So, I mean, it's just, I guess the question that people ask is, well, I want to do this stuff, but
yeah.
how do I get started?
Yep. And I always say too, if you can't, you're never going to find a guideline on how to do absolutely everything from a practical standpoint. You know, the Heart Health Guidelines of Canada don't talk about how to do cholesterol testing in a pharmacy. So sometimes you need to make up, I don't want to say make up your own rules, but set your own standards. You know, what is required for aseptic blood letting? What do I need to do for the consult? What's appropriate within my scope or not? And just start doing it. And talk to the providers, right? I always go to the docs and say, this is what I'm doing. Am I on point or not? And they'll just tell me, do this or don't do this. So, you're right, it's a challenge where to start.
Okay. One more question?
So obviously you've had a lot of success in Thunder Bay, and I think you did mention that you're opening up a location in downtown Toronto. Do you plan on doing these services in that setting as well, and how would you approach that differently in a bigger city like GTA or even Kitchener-Waterloo versus in Thunder Bay?
Yeah, absolutely. So where I'm going this afternoon, I'm just helping a site get set up for telemedicine. I'm not actually opening a full location, but Thunder Bay is an interesting market. There's 100,000 people. It's a geographical island. It's actually a really common test market for businesses. You heard about Walmart and Visa going head to head over their cards. The first place they did it was Thunder Bay because it's this little island. So if it works in Thunder Bay, some of the best practices you can bring and share and adapt to other locations. But you're absolutely right. Every environment is going to be different. The needs of the community are different. The practitioners, how they work, are different. But I think those are discussions you just need to have with the patients, with the providers in your area, and see how you can meet their needs. They may not want anything to do with osteoporosis bone density testing, but they might have been wanting INR testing for the last 10 years and no one's thought to go knock on their door. So I think wherever you roll out these little ideas or a full clinic pharmacy is, common sense, talking to providers and patients. So
one last question, Jeff?
I think you actually kind of addressed it with your last kind of comment. So I work in a more collaborative model and a hospital setting, and then we do get sometimes these faxes about like arrhythmia screening and CPD screening. And the very first question they ask me is, "Do you need the report?" And what do you want me to do? And I don't know anything about arrhythmia screening in the pharmacy. So how do you? And it's not due to the lack of my desire or our desire to collaborate with the community pharmacists, but I think there's certainly a disconnect between what the physicians want and what the pharmacy is providing. Because a lot of the times we find that it's very kind of pre-printed kind of recommendations versus kind of
tailored, individually written.
Yeah, notification. So so from my perspective, how do we work better with the pharmacies that are near us? Because a lot of the times we're very much in a cost-cutting mode right now in terms of choosing wisely kind of meet the objectives that we have now. So they are looking at these things, but should we actually be following up with some of these things that should have already had?
Right.
So how do we
How you navigate that? Yeah, again, if you send that doctor a cholesterol consultation note out of the blue, I've had them come back and say, are you billing the healthcare system for this?
Yeah.
I ordered this test 3 months ago. This is a duplication of service. I've had some kind of nasty letters come back. And that's where I learned, like, doing these things out of the blue is really not a good idea. So again, I come back to my last point there for implementation is those 3 pieces, is the detail aid, the referral pad, and the notification of service. But really what that involves is a conversation. In a bigger setting, as what gentleman here mentioned, it's not practical to go visit every single clinic in downtown Toronto. But if you have a physician who's maybe a city over to, maybe before you send a consult note, you need to have a discussion. Pick up the phone, talk to them, send them the letter, at least put an effort out to try to do it. Even if I get pushback from the physician or the provider, whoever it is, all of these programs, I know that I'm trying to do them in the patient's best interest, and even if I get that flack from the physician, I say, would I have done the same service for one of my family members? And the answer is yes. Then I have no issues taking some heat from a physician who maybe doesn't want me to do bone density testing, but the patient wanted it, and I did a good job, and I'm providing value to them. So thick skin, but do your due diligence to give them a heads up and collaborate. So that's my answer for that.
All right, thank you very much, Bryan. Very interesting approach to help us overcome a lot of the problems that we know the profession is facing now. So thank you very much.